Thank you everyone for joining. It's my pleasure and actually, a huge honor to introduce today's fabulous speaker, a close friend of mine, a fellow hospitalist, and a mentor, Dr. Andrew Auerbach, MD, MPH. We also call him Andy. So Andy and I started working together when he took up the role of editor-in-chief of the Journal of Hospital Medicine. Obviously, I learned a lot from him, particularly there were many occasions when he guided me how to evaluate an article for publication in the journal when I was on a fence about accepting or rejecting it. But I also learned from him what it means to be a good mentor, a good colleague, an academic hospitalist, lots of things I learned from him. So thank you, Andy, for accepting this invitation, for joining us today for Grand Rounds. Now, a little bit more formally, Dr. Auerbach is a professor of medicine in the Division of Hospital Medicine at University of California, San Francisco School of Medicine. He is also chair of the Clinical Content Oversight Committee for UCSF Health and leads the development and implementation of electronic health record tools across the UCSF Health enterprise. He is also a phenomenal teacher and has mentored more than 40 students, residents, fellows, and junior faculty over years. As a faculty in the Academic Hospitalist Academy over the past decade or so, he has also supported the academic development of hundreds of other aspiring academic hospitalists. Dr. Auerbach is also a nationally recognized researcher in the field of hospital medicine. He has authored or co-authored a seminal research describing the effects of hospital medicine on patient outcomes, costs, and quality care of healthcare. Dr. Auerbach research has been published in prominent journals, including New England Journal of Medicine, JAMA, Annals of Internal Medicine, and Archives of Internal Medicine. He leads a 13-hospital research network focused on new discoveries in healthcare delivery models in acute care settings, and more recently has founded a national collaborative seeking to understand how to adopt and use digital health tools in care delivery. Dr. Auerbach serves as section editor for Up to Date, and he is also the past editor-in-chief of the Journal of Hospital Medicine, a flagship peer-reviewed publication for the field of hospital medicine. He has received the Mac Lipkin Award for Outstanding Research as a Fellow and the Western Society for Clinical Investigations Outstanding Investigator Award. He is a member of American Society for Clinical Investigation, as well as Society of Hospital Medicine. Dr. Auerbach will be talking today about Hospital Medicine Reengineering Network, the HOMERuN collaborative. So VCU Department of Internal Medicine, and on his behalf, I welcome you, Dr. Auerbach, for our Grand Rounds today.
Well, thank you so much for the incredibly kind introduction, Rehan. It's really wonderful to be able to speak with you all. I wish it was in person, but I think that's kind of been the theme for the last 8 months. Hopefully not too much longer, but I'm going to talk to you today about the HOMERuN collaborative. Before I do that, I just want to disclose this financial disclosures. None of these are relevant to the talk today, but just to let you know, this is kind of how I get some of my funding. I want to give you the origin story of HOMERuN, which is the Hospital Medicine Reengineering Network. Talk about our Transistors of Care initiative, which is one of our foundational projects in terms of methodology and focus areas, because readmissions or transistors of care is a big part of what hospitalists have been focused on for the last 20 years. We have a group exercise. The limitation of this format is that I won't be able to have people hold their hands up for an answer, but we'll just kind of walk through it with you. I'm going to talk about the UPSIDE study, which is the Utility of Predictive Systems in Diagnostic Errors project that we're running, our COVID-19 collaboration, and then this end with a little bit of a kind of a strategic question that we're trying to grapple with at HOMERuN, which is how do we develop the hospitalist research pipeline, which is, I won't give away I won't be a spoiler right away, but I think, there are not as many as we think there should be hospitalist researchers. So the origin story here is this is a sushi restaurant in Northampton, Massachusetts, where I was visiting with Peter Lindenauer, a dear friend of mine, a colleague. We're having lunch. This is like probably maybe 15 years ago now, and we're like, where is the hospital medicine research network? The cardiologists have there, the intensivists have theirs, the emergency medicine has theirs. Why doesn't hospital medicine have one? So we wanted to leverage the role of hospitalists at that point in 1999, or actually at that point it was more like 2005. There was about 60% of Medicare patients were getting care from a hospitalist. There were 40,000, now 40,000 hospitalists across the U.S. That seems like a huge opportunity to do research, taking advantage of the frontline caregivers that we are. It was about the same time we published this paper about needing to improve care, but really not having a lot of evidence for the things we're doing. Was these broad-based quality improvement interventions, things like there are a lot of things in the 100,000 Lives campaign that were, good ideas, but had not been fully validated or tested in clinical settings. So like all good projects, we picked up the phone and called our friends. I happen to have good friends at these places. This is where we started a long time ago. So we're all over the country, but mostly, again, these are all hospitals that I knew would be able to pick up the phone, with Peter being at Bay State, which is one of the coordinating centers, and UCSF being another. We got a little bit of seed funding from AAMC in 2012. This was an interesting arrangement. The AAMC has not done much research development work, but they saw the value of engaging hospitalists in research. We would call it research, I would call it research, but they would call it evaluating quality improvement interventions. And because the AAMC has the ear of our department chair and our dean and our CEO kind of simultaneously, we raised the idea of a partnership around a health system engaged research program. So we worked with the AAMC, they got deans and CEOs involved with our kind of idea generation efforts. They helped us identify key opportunities, to identify our goals and our short and long-term tactics. We went into this with a very diverse set of research ideas that kind of largely emanated from researchers, and the CEOs and deans basically said, really, those are all very cute and interesting, but at this point, we're about readmissions. So we had to pivot from DVT prophylaxis or CLABSI, which were not unimportant, but they were not the burning issue of the day. They said, please help us fix the readmission problem. The key part that we heard in that process too was not so much fix the readmission problem, was also the idea that, many of you may remember this, in 2012, 2013, we were throwing everything we possibly could think of to reduce readmissions. So we were doing Boost and Project Red, and we had navigators, and we were doing post-discharge phone calls, and our health systems were saying, it's a lot of effort. We'd like to know which one of those is our most effective aspect, or where, if we were going to deploy more resources at a problem, which problem that might be. So again, we start off with a certain vision of the question. We had to move towards readmission, and then we had this additional value add question from our health system saying, okay, don't only tell us what number or proportion of readmissions are preventable, but tell us what we think we could do to make them less frequent, and which of those is most important. So here, the Transistor Care program, again, with AAMC was what proportion of readmissions are preventable, the contributing factors, so what is the pathophysiology of a preventable readmission, and then the potential benefit of different interventions underneath those two big buckets. So at a high level, our program at that point had audit and feedback of care practices that's basically gathering quality improvement data from our patients and giving it back to the unit. We evaluated the care practices of all discharged patients. We did a case review process for readmitted patients, and a site level survey for contextual factors. So UCSF was doing things very differently than the Brigham, and that was because we had a different payer mix here than they did in Boston, as an example. So we started this again, a long time ago now, but we looked at readmitted patients between April and December 2012, and then randomly selected cases for review and patient interview. They had to be a discharge from the last 30 days from the general medicine service. They could have been readmitted to any service for any cause. So if they came back to surgery, unless it was for an elective surgery, we would look at that. They were discharged with abdominal pain from my service and came back and had to general surgery for a surgery, we would have seen that patient. We did exclude AMA and scheduled readmissions. We probably should not have excluded the AMA readmissions because at the time, the ethical framework wasn't as clear as it is now that the AMA discharge is the same as a regular discharge. Just you give a slightly different paperwork. So of those 100 patients at each site, those are 12 sites, we had research assistants interview the patients to understand how they felt about their care, what the patients thought about the care. We asked the previous inpatient physician, the current inpatient physician, and the primary care physician what they thought the readmission was related to. We did a chart review that collected information about processes of care, such as medication reconciliation, how complete the discharge summary was. These are all things that our health systems were spending huge amounts of money on and wanted to know whether these were associated with readmission at all. And then the part of this that was both most time consuming, but also the most important, I think, was having two physicians review each case to figure out whether it was a preventable readmission and what the underlying causes of the readmission were. Just to back up for a minute, our program was built on a framework that was related to, but not exactly the same as ones that have been used for drug-related adverse drug events, where you have two independent case reviewers review the case, and then there are calculated kappas and things like that to figure out how much statistical agreement there is between reviewers. That was a great is a very valid and useful scientific approach, but in this research program, which is really a community-based participatory model, that just wasn't feasible. It wasn't feasible to have two of our physicians do the cases independently and then have a statistical agreement calculated. We wanted something that could scale and could be used by quality improvement leaders. At many sites, there are quality improvement nurses or not even nurses, MAs that are doing the quality improvement reviews. So we thought we adapted that kind of scientific process, the statistically driven one, to be replaced to use this more lightweight and scalable one. So what we gave up potentially in validity, we gained, I think, a lot in practicality and scalability. Our patient interview, just to remind you, it asked about a follow-up appointment. It asked about communication with caregivers, understanding of discharge instructions, knowledge of red flags, ability to perform self-care, social support. You can see these here, and these open-ended questions. As you might imagine, or might remember, everyone asked a subset, every hospital asked a subset of the discharged patients, the HCAP questions. So we had to subtly reword our questions and change them so they didn't replicate HCAP's questions. So some of our results were a little different, but the general idea was the same kind of thing, satisfaction with the provider, understanding communication, and so on. We asked them what they thought brought them back to the hospital, understanding, ability to self-manage, social support, and so on, as you can see them here, and then asked them to suggest what would have helped prevent the readmission. The adjudication process, again, I mentioned this before, is 2 to 3 physicians at each site were kind of charged to do these 100 case reviews. And then we said, use as much of the medical record as you think is necessary to look at to make a reasonable assessment of the case. At that point, many of us had been transitioned to electronic health records, a little bit easier, but actually, interestingly, a lot of them were just in their journey. So there was a fair amount of paper at the time. So that's how the individual sites did it. But we trained 50 or so adjudicators through a set of standard cases that we did on a phone call every week for several months. And then each site submitted their own case so that the group could adjudicate. So we have inter-site reliability, and that, again, going back to the idea of some statistical validity and robustness of our results. That's the way we did this at scale. Again, slightly different than the statistical approach that would be used in a classical epidemiologic study, more of a practical participatory model. And just so you know, this is what it looked like. The readmission, there are some factors here that could have been involved here. So this is an example of the kind of the upper half of this shows you a particular idea that this one is monitoring and managing symptoms that has, what is that, 5 different potential options under it. The bottom down here is the preventability. So this is the readmission preventability assessment. Just draw your eye to the 6 different categories here with the less than 50-50 and more than 50-50 breakpoint. That's a key methodologic approach in most error in safety studies, just to not allow people to kind of go, could have been either one. We want to maybe make people put their nickel down, as they say, and say which way the preventability leaned. Then we asked, so once we defined preventability, we then asked which of these, there's about 17 different factors here, would have prevented the readmission. And this is just 2 examples here. Again, the same kind of scale there. So what happened is I would sit in my office with a cup of coffee with my friend Ryan Grayson or Michelle Murad, and we would look at the cases independently, and we'd sit down. One of us would be the primary reviewer. I'd say, Ryan, this is how I saw the case. He said, well, I saw it a little differently, and we would kind of come to a negotiated settlement on each case and decide what was the most reasonable way to interpret the data. If there was a disagreement, then Ryan and I would turn to Michelle and say, Michelle, what do you think? And she'd say, okay, you two, this is what I think. And that'd be the tiebreaker. In really difficult cases, they brought it back to the big group. So we'd have a large group discussion. It took time, 15 to 35 minutes per adjudication, and faster as it went along. I think there's an important concept here. And I think it's a safety concept, which is one that we were probably one of the first to think through in this way. There's and for us, the standard preventability was really about an error or system design flaw. One that could have been avoided with reasonable patient or physician action. We don't necessarily take the physician responsibility out of it, but there's the system and design flaw part of this is key. The part I think that we added was, don't assume an ideal society. Like, you can't assume that homelessness will go away, but you should assume an ideal healthcare system. So for the care of a homeless patient, what would be the most reasonable and feasible ideal health system adaptation to it? So any intervention that's likely to prevent readmissions and which is likely to be cost savings to society, not just your health system, was something we would have thought was a potentially useful intervention to reduce a preventable readmission. If it's not available and it would have prevented the readmission, then the readmission was preventable. That makes sense. So we didn't assume we're going to cure cancer. We didn't assume we're going to solve all of society's ills, but we did take the view that the health system and hospitals should be more active in pushing our health systems towards a more ideal state. The preventability determination. So some things that could make a readmission preventable: patient non-adherence, didn't understand, inadequate symptom recognition. You can see the list here. So again, this would be where I would, if we had a audience participation system, this is where I would have you all put your hands up. So I'll see how this goes without it, if that's okay. So these are actual cases ripped from the headlines, as they say, from these cases a while ago. So 63-year-old lady discharged from, I'll say, at our hospital after admission for viral meningitis. She actually had herpes encephalitis and was on prolonged oral acyclovir therapy. She arrives at the primary care doctor's office 4 days after her discharge with a severe headache and low-grade temperature. She's 108 there in the clinic. She feels neither are improving. So imagine, those of you who are primary care doctors, imagine this patient arriving in your clinic with those symptoms. And rightly, those of you who are primary care doctors say, this is a woman who's got a viral encephalitis, comes with a fever, headache, and neither are getting better. I should probably send this patient to the ED. So the primary care doctor sent this patient back to the emergency department for urgent lumbar puncture, and when the patient was admitted. So the next morning, the patient is seen by the same ID consultant who had seen her 5 days earlier, 6 days earlier, and says, "This is if the notes were available, they would have noticed how the patient was probably expected to have these sort of low-grade temperatures and headaches for a while, and that there was no additional workup required, and the patient was discharged that day." So in the case review, the med rec was perfect. The med list was pristine. The discharge instructions mentioned taking the meds as instructed, keeping appointments. Discharge summary had been completed but faxed to the PCV office on the day of the clinic visit. So it's sitting in a folder or on a fax machine. The follow-up appointment was scheduled within 7 days. The patient got to see their primary care doctor on day 4 after discharge. That's pretty awesome, at least in terms of what we'd think about as a benchmark. As I alluded to, the PCP felt that she had to readmit the patient. And the patient said, "I understood the plan. I was able to take the meds and take her appointments, but didn't feel she was getting better fast enough." So what caused this readmission? And again, the artifact of Zoom will make it a little hard for us to discuss this in some more detail, but the patient inability to self-manage, poor choice of post-discharge support, SNF versus home, poor communication of discharge plan between providers, discharge too soon, incomplete discharge instructions, errors in triage at the time of representation. These are not all the factors, but these are the 6 that we'll kind of check through. So I'll kind of march you through the way this case is reviewed. So we thought it was mostly about poor communication of discharge plan between providers. Incomplete discharge instructions, not so much in that the MedRec or the discharge orders or the discharge instructions were bad, but they didn't really seem to connect with the patient in the way the patient was found useful. So the patient didn't really know, wasn't able to relate to the idea that she was going to probably have a headache for a while and have low-grade temperatures. And there was no additional information about red flag symptoms, like, okay, you're going to have headaches for a little while longer, 2-3 weeks, but if they persist beyond that, please come back urgently. Like, that wasn't in the medical record. So that's what we said here. And then errors in triage at the time of representation here. We'll get back to this in a little bit, but this, the ED and the primary care clinic were both kind of held. It's hard not to admit this patient again. So, but an ideal health system would have potentially figured out that this patient didn't need to have to come back in the hospital for all things we talked about in the case. So this is errors in triage of representation. Was this a preventable readmission? Again, reminded this is an error, our system design flaw. We can I assume ideal healthcare system. This is the schema. Remember the 6 levels. We in this case thought this was strongly probable. In the room, we would be putting up the audience response system, but I think this, just so you can think about this yourself, and maybe we can come back to questions about this at the end. This is the second case, and I will go through, and I think this will come back at the end when we talk about diagnostic errors as well. So 55-year-old man, history of advanced pancreatic cancer, comes with a partial SBO, vomiting, dehydration, gets IV fluid over a couple days, antiemetics, seems to get better. Those of you who are acute care physicians probably know this scenario. You've been waiting for 3 days for this person to start to eat. They're starting to get hydrated. You come in the next morning, their breakfast tray is largely empty. You say, "How are you eating?" The patient says, "I did okay." And then they, "Great, how do you feel about going home?" Patient goes, "Great, I'll try to go home." That's essentially what happened here. The patient was, the diet was advanced. The patient was ostensibly tolerating the diet on the day of the discharge and was discharged that evening after having their activity and diet advanced. Sadly, he came back in 3 days with recurrent vomiting and new AKI. So again, the MedRec, I'm a chair of the MedRec committee, so I'm proud to say this. MedRec was perfect. Discharge instructions described no dietary restrictions. The discharge summary was completed. He had an appointment followed in 7 days. But he was readmitted before seen by any ambulatory physician. He's back in like 72 hours, so there's no way for a primary care doctor to see him. The discharging doctor felt the patient had advanced to full diet and was tolerating it well at discharge. The PCP had no idea the patient was admitted. The patient was in the hospital for 4 days and never heard. The readmitting, so that was interesting feedback. So readmitted MD felt the patient had failed a trial at home. The patient was super interesting to talk to. He felt he really hadn't eaten much before going home, but he was able to take in his juice and oatmeal. He felt okay about going home, but still a little bit worried. He was willing to go home and he was kind of excited to go home. He was a man who was, knew he was close to the end of his life and wanted to get home. So after arriving at his home, his medication didn't control his nausea. He tried to tough it out for 3 days before returning to eating. This patient maybe feel familiar to you. So go through our same set of criteria. Inability to self-manage, poor choice of post-discharge support, poor communication, discharge too soon, incomplete discharge instructions, error in triage. We called at least these two here. So inability to self-manage, again, not putting this on the patient in terms of like you didn't know how to take your Zofran or how to advance to Compazine or how to drink Gatorade if you were losing losing your PO intake. But just we didn't do a good job as we could have to help him with that process with instructions or additional calls or whatever by our institution. And this is a case we did call the patient is probably discharged a bit too soon. I think he came back so quickly that and he said that he was worried and hadn't really taken a full PO diet, that he would maybe have been discharged too soon in the first admission. And this is a result that came up quite a bit in our discussion of the final results of the study. Was it a preventable readmission? Again, we can talk about this later. I think this one we called less than 50-50, but a close call. I think it was a very patient-centered idea to get him home. He wanted to go home. There's certainly, you can't keep people in the hospital forever. They have to go home at some point. But what we were worried about here was the idea the patient had related that he was not completely comfortable with the amount he was eating before he went home. So this was a less than 50-50, but a close call. All right, so taking you through two cases, imagine doing that 1,200 times, which is what we did in this study. We took those 1,200 cases and all the variables we collected. We looked at the factors. We looked at the numbers of patients who were preventable, proportion, and we looked at which factors in those preventable patients were associated with preventability. So we looked at the most associated risk factors or problems. And then using those numbers, the odds ratios for all the things that were associated with preventability, then calculated the population attributable risk. So we said, if something is very, very common, I'll pick a number like patient unable to self-manage, and the odds ratio is 2, that would be more bang for the buck, a higher population attributable risk than something is much less common, but the same odds ratio, if that makes sense. So highest priority areas based on prevalence of risk factor and associated risk. And what does that look like on a table? So this is the table from the paper. You have the preventable readmissions on that left-hand column, the non-preventable readmissions on the right. You'll see the statistically significant differences in our patients. Turns out they were reasonably well matched. This is just the patient characteristics. So interestingly, readmitted patients were all reasonably similar, at least in appearance, based on their kind of baseline kind of sociodemographics and clinical care. But here's the preventability numbers. So about 30%, 27% here were patients we felt had a preventable readmission. This is roughly the same as a large Canadian study that came out at the same time. And most of the preventability was in the hospital, where we had an opportunity to do something slightly different. If you blend in the multiple locations, it's probably closer to 60% of the admissions had some role of the inpatient care. So as a hospitalist, this is pretty humbling. We have an opportunity to do things quite a bit differently. So these are the results of the multivariable models. Just so you know, again, carrying this idea forward of the population attributable risk. Just draw your eye to a few of these here. So you've got your discharge too soon is a pretty high odds ratio, and it's also pretty prevalent. So the proportional portion of preventable readmissions that would have been eliminated if we had been able to fully implement an intervention about discharging too soon would have been we would have reduced about 9% of all preventable readmissions. Same with ED decided to admit a patient who may not have needed to stay, 8 for not able to keep a post-discharge appointment, and then not able to, unaware of who to contact after leaving the hospital. If you had to, these are the top 4 items. There are a few that kind of barely missed the cut, but just that's the value of this population attributable risk method. These are all statistically important. They're very important targets for your health system, for our health systems. This is the information we gave back to our CMOs. These are all the ones that are most important. But if you had to kind of work the pile down from the highest impact issues to the least impact or less impact, you would start with these 4 items. So patient not able to keep post-discharge diagnoses, patient lack of awareness, patient discharge too soon, and then this ED admission question. Now, just to emphasize this, because it was a key to the first case as well, is I got emails from close friends and colleagues who are emergency room physicians, and they said, this makes us look terrible, Andy. Why'd you write it this way? So this is the way the question was worded on the questionnaire, which I regret. But operationally, it's much like that first case. It was not so much about the ED being bad doctors or not being respectful of hospital resources, but really being stuck with patients who have poor access to primary care. Our documentation about the last discharge is poor. The clinics are overwhelmed and the patients are extremely sick with complicated issues. And in a 20-minute post-hospital follow-up, that's impossible to do much more than triage. So I think that for us, I would hate for you to take away like the ED is a villain in this. They're more of a innocent bystander in a system that's not working as well as we think it should. Oh, and one other thing to bring back here, I do want to, because this is important for the upside study, the misdiagnosis during the index admission was something we have carried forward. Again, I'll bring your eye to that because it's going to come back later in this discussion. What about 7-day readmissions? So 2 years ago, we looked at the same data. We looked at preventability in early versus late readmissions. It turns out preventability is much higher in early versus later readmissions. There are fewer of them as compared to late. And then the ideal location becomes much more heavily weighted towards the hospital early and much more towards the outpatient clinic and home for the later in someone's stay readmission time. So not surprising, but the first time we had seen, one of the first studies I think that has done a good job looking at the late versus early readmissions. And I know Kelly and Shawnee at the Beth Israel are trying to think about ways to move this into policy. The 3rd-day readmission measure is still what it is, but this is adding to the argument that 30 days is maybe much less specific than policymakers would like to see in terms of where the locus of energy should be. If you're Medicare, where should you be putting your investments or penalties? Again, if you look at preventability, it kind of really tails off after about day 8, day 9. I'll quickly go through this, but I'll just, if you remember, and this is fascinating for me because it's, again, as a hospitalist and wanting to work effectively with my colleagues in the primary care clinics and ED, you remember we interviewed all 3 of those doctors for our cases, or we surveyed each of them about their patients' readmission to see what they all saw were the problems, because we thought all of them had valuable viewpoints about what could be done to reduce readmissions. So we have a column here for primary care doctors, for discharging doctors, and the readmitting doctors. If you kind of look at the list of patient understanding of the factors contributing to readmission, they're roughly the same in terms of proportion. They're in the same general order in terms of like the most common to the least common reports. So if you look, they say, well, we're all kind of seeing the same problems, right? So these are the aggregate numbers. This is the report for all of the the providers across all the responses. But if you look at the cases where 3 physicians responded about the same patient, so Mr. Jones, we asked the 3 doctors involved, there was extraordinarily poor agreement between what I saw as the problems, what the next hospitalist saw as the problem, and what the primary care doctor saw as the key problem. So if you're in a room together, or unless you're in a room together or reviewing cases with your primary care doctors, it's going to be very difficult for you to develop a program which kind of meets everyone's needs and sees the full scope of a patient's experience and the health system problems. So again, this was, I think, for me, super fascinating, very humbling, but fascinating. Again, just a quick summary. This is a kind of a midpoint discussion. So again, the opportunities to improve care for discharge too soon is really a key one, with access to primary care being a part of the readmission issue. A lot more focused in inpatient setting for earlier, and then the preventability targets is going to be hard to target unless you work as a team. So that's like a midpoint discussion. We're at 36 minutes, and I want to get to the more recent stuff. But I thought it was important to talk through our Readmissions Project, because it's really foundational what HOMERuN has done, and it's allowed us to build the things I'm going to spend the next 20 or so minutes talking to you about. Just so you know, the other things that came out of this project are here. We're very proud, and lots of great work that came out of the group. Just feel free to pull them up, and I put them up here mostly to let you know who the amazing team was and is on that initial project. Our current HOMERuN efforts. So we have had a series of projects that have spun out of the original Transistors of Care. We looked at our readmission tools for broader use. We're starting to make those useful for a number of sites. The very important patient in your hospital is a recently hot topic. We did a nice study with Joshua Allen Dicker, who's now at Sloan Kettering, looking at the existential challenges hospitals feel when taking care of a VIP in one bed and the same patient next to, like same kind of patient in the bed, next bed over, how they get different care. So that was a nice study, and we're trying to replicate that. We're looking at CBC utilization in pneumonia patients. It turns out the only useful CBC in a patient in pneumonia, at least in our little pilot study, is the first one. After that, it's really about vital signs and exam. So don't get QAM vital CBCs is the headline from that one, which I thought was interesting. We have a patient and family advisory council, which has been really active in framing a series of research projects that we're spinning up. So, and again, that was an extraordinary side effect of the first study, because we had patients deeply involved in the identification of the problems and the generation of the tools. This has led to a project we're doing right now called the Upside Study. It's the utility of predictive systems and diagnostic errors. If you remember, on the list of statistically associated items with statistically associated with preventable readmissions, diagnostic errors was one. So we're using a similar methodology to look at the incidence of diagnostic errors among patients who die in the hospital or are transferred to the ICU 2 days or more after admission. Again, we're looking at these medical centers affiliated with HOMERuN. We're going to use the adjudication data from HOMERuN sites and then administrative data from Vizient, which is what UHC is called now, to look at what factors are underlying diagnostic errors. Again, think about that last table I showed you, population attributable risk. So what's the population attributable risk for certain factors that produce diagnostic errors? And then we're going to use the combination of those data to create machine learning models that we can use to identify cases where a diagnostic error might have taken place. We're now deep into AIM 1 and AIM 2 and AIM 3. This is AIM 3, it should not be AIM 2, are underway kind of analytically. These are the sites. We have about 31 sites with a reasonable number of, not as many as I would like, but we had to stay within our budget of non-teaching but university affiliated hospitals. So about 32 sites, about 100 cases at each site. We had the 34 hospitals there. We've got the 3 safety net, 10 community, 21 AMCs. I mentioned about the Vizient data. And then our adjudication will be much like the readmission study. 2 providers, 3 in some cases, reviewing each of the 100 cases. So I'll return us to our friend, the 55-year-old man who had the pancreatic cancer. Maybe he had the SBO discharge a little too early, perhaps. I'm going to remind you of the case scenario. He felt like he wanted to go home. The doctor thought he was willing to try it, had to had to fail to trial at home. So this model we're using for Upside has 3 key features. You may not have heard of all these, but there's a tool called the SaferDX tool, which has come out of the ambulatory space. Hardeep Singh in Texas has really promulgated this for use in ambulatory settings. It hasn't been as well tested in inpatient settings. So one of our first tasks was to adapt it for the inpatient setting. Much of what SaferDX does in terms of assessing whether or not a test was followed up on adequately, or a physician made a cognitive error, are not different in the hospital. But there are other things like handoffs and shifts and things like that, which are maybe more intense and more frequent, that we had to adapt the tool to. So the SaferDX is used to define whether a diagnostic error took place. And then we use a standard level of harm scale, which is used in many safety areas of research. I'll show you the example in a minute, to say, well, if an error took place, what was the level of harm that was imparted? And then we use this thing called the DEAR taxonomy, which gives us the underlying causes, the pathophysiology of the error. Again, the reason I went through that long pedantic exercise of the Transitions of Care project is it's largely the same general idea we did before. The DEAR taxonomy gives us the underlying interventions we might use to address diagnostic errors. So this is just an excerpt of the SaferDX criteria. You can see the documented history of suggestive and alternate diagnosis, physical exam, alternate diagnosis, diagnostic. You can see this. This is the alternate diagnosis section of there are about 26 questions on the SaferDX. And we have a strongly agree to strongly disagree with no neutral category, again, to avoid people from sitting on the fence. Again, each of these criteria, there's about 26 of them, is then used to have people put their nickel down again, whether or not a diagnostic error took place, a missed opportunity to make a correct or timely diagnosis based on the available evidence, regardless of patient harm, is a diagnostic error. So that's like standard diagnostic error definition from the National Academies. We then assign the harm level. Again, category A through I here this is standard one. I'm happily share the slides afterwards so you can take a look at. This is something that came from a variety of different safety rules, safety intervention trials. And then people jump into the DEAR taxonomy. And there are 8 sections here. I'll give you an example, just the access and presentation. So in this case, who knows what you would have checked off, but I think for this one, the SaferDX, I would have checked off failure to collect adequate data from the patient. Like we didn't actually get a full PO intake or level of his anxiety about going home. The harm was category F. He resulted in a prolonged stay. And then didn't show you the entirety of the DEAR taxonomy, but there's some inaccurate, misinterpreted historical data, inaccurate, misinterpreted exam data. We suboptimally weighted the patient's history that morning, and then over-reliance on secondhand info, which in this case was the nurse, not written in the note, but the nurse that said, I think he had all of his breakfast. The tray looked empty. So, but she had actually, busy in and out of the room. The tray was there, looked was eaten, but it had disappeared. The dietary services had removed the tray. So that was kind of over-reliance on this idea that maybe he had actually had a fuller breakfast than he had. So giving you a preview of this is going to look a lot like the Transistors of Care project, except in this case, we're going to have 3,200 cases of ICU transfers or death. This is a readmission, so it would not have gotten into our study, but I want to give you a sense of how this would work. Pivoting, the other thing we're doing right now, because it's the thing that is occupying all of our minds, is we're supporting a lot of COVID-related research now. This is our kind of mission or framework for doing it. We've got a weekly phone call, a webinar of about 65 hospitals that are sharing best practices around COVID-19, and then really think about quickly identifying problems, designing studies, doing a lot of surveys, cross-sectional studies. We're thinking about how ways to link to EHR data in the future, but not making that a key issue right now. Really thinking more like if you've worked with the IHI breakthrough series, which is a 6 to 15 month learning system model, where we're trying to generate evidence from our collaborative, give it back to the people who are participating, and then continue those cycles. So this is generally what we do. We identify a core challenge, we form a team, We identify the key questions. We gather information from the sites. We review materials from that information to identify promising answers and summarize and disseminate the answers. We do that by webinars, materials on Dropbox, website, and papers. If you go to hospitalinnovate.org, you can see some of the content there. We have a few topic areas that have been completed. So discharge practices, VTE anticoagulation, and workforce adaptations. We have a provider well-being page that will be up probably hopefully by the end of the week, a patient experience section that's up hopefully the week after. I am leading a group looking at clinical practice guidelines. We were going to do this earlier, but there was so much mayhem in terms of what we thought we needed to do for COVID patients that it was really hard to get any consensus. So now we're at the point where we have a more stable, at least stable set of clinical practices that we can start getting our arms around. Looking at medical education challenges in the COVID-19 era. Most of our sites did not allow learners to take care of COVID-19 patients early in the pandemic. Now we're trying to figure out ways to bring them back in. And then equity, social justice, and anti-racism efforts is another key topic area we're spooling up. This is the website again, hospitalinnovate.org. We've got these three up. You can look at the overview, you can look at the references, all this material. You do have to log in just so we can keep you updated when things change. And this is just an example of the front page with thrombosis and a thromboembolism anticoagulation group. And this is not a live web page, but you can click into the key questions we studied, and there are things like optimal dosing of heparins in patients with now known DVT, diagnosis of VTE in patients with COVID, that kind of thing. So this has been a huge amount of work. Can't say enough for these amazing folks that have been involved. It's really been a great effort. And again, thanks to the Moore Foundation for funding this collaborative. It's really been out of hard work and passion. I wish I had more money to pay them. It's just been an amazing effort. In the middle of all this, HOMERuN is, again, I alluded to this earlier, that we're about trying to support the field of hospital medicine. We had surveyed 86 hospital medicine programs that just to ask them about how many researchers and what their academic focus was. Only about half responded, but still not a bad number. When you look at those 43 sites, there are about 2,500 hospitalists at those 43 sites. Of those 2,500 hospitalists, only 79 were clinician investigators. 2 of those sites contributed about a third of the total number of investigators. And there were only 15 K awards, 7 of which were at those same 2 sites across those 79 clinical investigators. It makes me wonder like what the other 60 or so are in terms of actual investigators. It's hard to be a researcher if you're not funded. And if you went to 43 divisions of cardiology, 43 divisions of geriatrics, 43 divisions of pulmonary, I suspect you'd have a very different answer. Again, I think most of these R01s are at the Brigham in Michigan and maybe here. So if you take them out, there's not that many out there. So just very, very concerning for the field in terms of where the pipeline of academic researchers, hospital medicine researchers are going to be. There's a large differential diagnosis, and with the department chair here on the call, I will not get into them in too much detail, but I think most of the funding comes from hospitals and health systems, not from the departments. There's lots of issues here that we're trying to get our arms around. But HOMERuN's role really is just thinking about these 3 key things. We have to build a pipeline. So part of what HOMERuN does is mentor junior faculty and fellows. We try to support the teams, which is provide the opportunity to network and collaborate. We catalyze projects, which is collaborative models, access to data infrastructure, access to smart people to help them be successful. If I come back and talk to you all in a couple of years, hopefully we'll have actual programs in place. I can't talk about them too much right now, but we're actually trying to spool up actual programs to do this. But I think in the short term, this is really what, when Peter and I were having sushi in that restaurant a long time ago, it was about the research, but it's really about this, which is about how do we take a specialty that didn't exist at that point 10 years earlier and make it into a full-fledged member of internal medicine's academic community. So that's really where we are now. It still continues to animate us to this day. So We're a practice-based research network. I think, that is what we're about. We don't like to helicopter into a hospital and then helicopter out when our project is done. We like to do what the hospital and health systems think is important. We like to partner. We like to leave them when funding runs out, or otherwise with something that's durable. We try to understand the underlying pathophysiology of patient problems so that interventions can proceed. And then we really, again, I can't emphasize enough, we're really about developing additional research and researchers in hospital medicine. And again, this is my last slide, but I just want to put the names of the folks who are the founding members of HOMERuN up here. Again, this is really a team effort, has been a team effort since the beginning. And would be remiss if I didn't mention them here. With that, I'll just say thank you again, and I'll take any questions.
Thank you very much, Andy. Thanks a lot. You covered really a very wide area in this short period of time. You talked about readmissions and then errors, diagnostic errors, COVID-19, and then mentorship issues in hospital medicine and hospital medicine research. Obviously, there's a lot that can be asked, but one thing that particularly is of my interest is in developing research within hospital medicine, and where I find it somewhat a catch-22 situation or a chicken and egg situation is where if we don't have enough mentors, we can't have enough researchers, and if we don't have enough researchers, we can't have enough mentors. Right. And the interests in hospital medicine are somewhat not as much overlapping with interest with other divisions in the Department of Medicine or otherwise. Our interests are more system-based interest, QI interest, those type of things. And just wondering what your thoughts are around building mentorship and that structure within hospital medicine that can help to develop those investigators.
Yeah, so I'll back up a little bit to I blew past the differential diagnosis slide a little bit. So I think outside of a few sites, there aren't that many hospital medicine research role models, and so it's hard for people to envision what their future might look like. So that's like the first leaky step in the pipeline that goes from a medical student to someone being recruited to be a researcher at a division or a department. There's a lack of people who are research trained and want to be hospitalists that we can, or maybe they don't know either. I think we've talked to people in the National Clinical Scholars Program or in the T32 programs around the country, and most of them don't have exposure to a hospitalist researcher or know how to get involved with inpatient acute care medicine. So that's another thing we're working on, trying to figure out how to get our HOMERuN mentors visible. And not that HOMERuN has to be all of the model, but I think that's another issue. How do you get people aware of hospital medicine as a research career at the Hopkins, UCLA, whatever, those kind of programs where someone who does disparities research on inpatient translation, interpreter services, like, oh, well, maybe I could practice as a hospitalist and do my research as well. Like that doesn't seem to cross people's minds as much as it should. There are not enough fellowship programs, period, that do research as a primary goal. I think both I and other colleagues in our network have put in T32 grants that the NIH has given us feedback that we don't believe there's enough hospitalists interested in this to do the work. So that's another leaky pipeline issue. But I think, just to kind of, without going on, because it's a subject for a much longer phone call right now, I think the issue of just making people aware of hospital medicine as a research career is a key part of it. I mean, hospitalists are often brought in to fill really important clinical and operational needs, and how to surface the idea that research, funded research, is a viable career path, is just as it is for cardiologists or pulmonary, something that really does come from the deans. It has to come from the department chairs locally. And then if that happens, I do believe, and I think one of the advantages of being where I've been is that came from my department chair and my department division chief from the beginning. It was, we can't have a division without those sorts of things. I think I'm looking at you and not put you on the spot, but I think it really comes from the School of Medicine, Department of Medicine side as a first step. And I think people are starting to realize that because, now, divisions of hospital medicine are bigger than cardiology. They are often 200-300 people at some sites if you start rolling in palliative care. So the department chair is like, whoa, where's your grant funding? And they say, we don't have any, and that causes some internal angst. So anyway, longer discussion, but I feel hopefully that got partway to your answer.
Thank you. And, other thing is that those hospitalists who want to join this HOMERuN project, if you can tell how they can do that. I know the process, but there are others also on who are listening so that they can. Yeah,
please. So please, you log into the site. You can sign up to be part of the HOMERuN listservs and so on. And then as you we have a somewhat organic approach to proposing research projects, just because that's how research tends to develop. But if people have ideas for data analysts or grants they want to put in, they need more than one site or want to do surveys at more than one site, please just go to the website and sign in. You can also just email me. That's an easy way to get started if you get lost.
Thank you.
So I'll stop sharing my screen if that's okay, or I can put it on. I don't see any.
All right. Well, once again, thank you very much, Andy, for joining us today. It was really very useful and helpful lecture. I've been getting texts about how good your lecture was, and really exciting information, knowledge, particularly about HOMERuN. Quite a few of our hospitalists are interested in joining that, and they'll be sending an email out to.
Very good.
HOMERuN.
It was really an honor to be invited. Thank you for your time, and again, I hope we meet someplace in person in the next year.
Definitely. Thank you very much. Take care.
Take care.
Bye-bye.